So good morning, everybody. Welcome to our session on new treatments for congenital disorders. My name is Thomas Eggermann. I'm from the University Hospital in Aachen, Germany, and I'm very proud to present today two experts in the field of developmental of treatments, clinical trials, and research on it. But first of all, I would like to ask you to switch your mobiles off. And well, I also want to welcome the audience which is online participating now. Later we'll have time for questions, but first of all we have two presentations. Anna David will start. Anna is the director of the Elizabeth Garrett Anderson Institute for Women's Health at the University College of London, and she's professor in obstetric and maternal fetal medicine at the University College in London. Her clinical practice covers fetal medicine, severe congenital disease, fetal growth restriction, and prevention of preterm birth. Her research team is developing novel prenatal therapies using stem cells and gene therapy for severe and life-threatening obstetric conditions and congenital diseases. She has led the development of the first international consensus for maternal and fetal adverse event terminology, which is now transforming safety assessment in clinical trials in pregnancy. So thanks a lot, Anna, for coming, and the floor is yours. Thank you.
Thank you very much, Thomas. Thank you. Welcome to everybody. And thank you for inviting me to come to the conference in person. I had a lovely time learning about prenatal exome sequencing yesterday at the workshop, which was very interesting, and looking at all the abstract posters. So really happy to be here in person. These are my conflicts of interest. I have funding, obviously, for treating prenatal therapy, congenital diseases. I have grants, and I'm paid as a consultant for Esperaire to be chair of their data safety monitoring board for a clinical trial of genetic therapy for an X-linked skin disorder, which I will be talking about later. So my learning points are here. What I hope by the end of this session is that you'll have learned about recent advances in prenatal genetic therapy, and to appreciate the challenges of developing a prenatal genetic treatment, to understand ethical and legal considerations, and I'm going to be showing some data about what patients think about this, and to find out about new ways to assess safety for clinical trials in pregnancy, because safety is the #1 primary outcome measure that we should be doing for all first-in-human clinical trials. And that's been quite challenging to be able to assess safety for the mother and the fetus in pregnancy trials until now, and I'll show you some recent terminology that we've developed. So I'm a fetal medicine specialist. I do a lot of prenatal diagnosis using ultrasound. I do invasive testing, and I do also take part in treatments, for example, open fetal surgery that we do at UCLH, my hospital, for spina bifida. We do fetoscopic surgery for congenital diaphragmatic hernia, and we also do blood transfusions for babies that are anemic. For instance, we've recently started offering it for babies that have alpha thalassemia major. But these things are relatively uncommon, and there have been occasional case reports of treatment for genetic therapy. And of course, you'll have heard, and there's much out there about stem cell transplantation and genetic therapy and gene transfer, and gene editing is coming our way. So can we perhaps use these interventions to treat the fetus before birth? Why might we want to do that? Well, there are a number of quite powerful reasons why it might be sensible and actually more efficacious to treat the fetus before birth. So for those diseases that are early onset and have pathology before birth, we would hope to treat, and perhaps not necessarily completely remove all the phenotype, all the pathology, but treat before irreversible damage by disease. There are some cells and organs that are more easily accessible in the fetus. For example, the fetal lungs are full of fluid, and if you want to target the airways, then you can actually target therapy into the fluid-filled lungs, which may be more effective. There's more efficient gene transfer and engraftment. So you get, in some cases, we've had evidence of higher gene transfer to cells that are in the fetus, for example, the fetal liver compared to the adult liver. This is from preclinical studies. And in terms of targeting cells, if you do a transplant into the peripheral circulation of a neonate or an adult, for example, you're thinking of mesenchymal stem cells, many of them will fetch up in the pulmonary circulation. Whereas if you transplant into the fetus, you probably would go into the umbilical vein, and due to the circulatory diversions that there are in the fetal life, you bypass the lungs, and therefore you achieve a higher engraftment, a higher exposure of your systemic circulation to these stem cells. And this is particularly, we've been trying to do this for in utero stem cell transplantation for brittle bone disease, where we're giving mesenchymal stem cells into the umbilical vein in neonatal life, in fetal life, sorry, not neonatal life, fetal life. There's also this concept of a functional immaturity of the immune system. So it's very clear that the fetus is able to mount quite a robust immune response from quite early in pregnancy. There are B cells available from 16 weeks of gestation and T cells available probably from around 18 to 20 weeks. But we do know from mouse studies that you can actually cause the fetus to become immune tolerant to antigens or allogeneic transplantation by actually transplanting in utero. And that is the hope for many of these conditions. And there's also a fetal size to vector stem cell ratio. So the fetus at 20 weeks is only going to be around 150, 200 grams. And if you have a very expensive product, particularly gene therapy or some kind of stem cell transplant, it's very expensive to manufacture. And so you have a huge cost advantage if you can give it safely into the umbilical vein under ultrasound guidance when you have a genetic diagnosis, then that probably has a real cost advantage. You will all know about the burden of genetic conditions and that there's a high rate and a high cost to single gene disorders. And many of these are now being diagnosed in utero. This is, for an example, just from the NHS, and we heard yesterday many of you in the prenatal exome sequencing workshop are actually offering finding single gene disorders in utero. Currently, the genomic test directory in the NHS offers, as you can see here, these tests non-invasively, and there are bespoke tests being developed, microarray analysis, and lots of abstracts about whole exome sequencing. So patients are going to be asking, I think, in the next decades, well, you've made a diagnosis in my fetus, can it possibly be treated before birth? So there are a variety of ways, tissues that you can use, stem cells, as you'll know, many successful transplants, bone marrow, umbilical cord, and now peripheral blood being used. Gene therapy, which I'm sure you'll have heard about, which uses the genetic machinery of the cell to produce a therapeutic protein or replacement protein. And then, of course, there's gene editing, which creates a targeted double-stranded break in the genetic material, which is then repaired and to produce a therapeutic effect. Also, less stressful and less difficult to do is perhaps protein therapy. If you have a disease where you need to have this particular protein available to the cell or the organ at a particular type of gestation, particular time of gestation, then actually just exposing the fetus to that particular protein may cure the genetic disease. And this is something that is being used for this excellent skin disease. It also may be possible to buy time for a fetus that has a severe enzyme deficiency, for example, mucopolysaccharidosis, where you may be able to treat by giving in utero enzyme replacement therapy before birth, and then after birth you might be able to treat this using gene therapy or potentially continue using enzyme replacement therapy. So there are definitely ways that we could do it slightly easier rather than going straight into genetic manipulation. Candidate diseases, there's a long list here, but most of them, they should be severe, life-threatening, early onset, and most importantly, diagnosable in utero. So what I'm going to cover is take you through some of the history. There are some clinical trials that are actually open to patients to treat congenital disease in utero, and I'm going to take you through and show some of those. So if we go right back to the beginning, the first case report published in 1996 of stem cell transplantation in utero was for X-linked severe combined immune deficiency, where the individual underwent a fetal transplantation of paternal bone marrow by umbilical vein infusion, and this person is now well, is cured of their X-links of their SCID. And this, of course, the fetus is unable to mount an immune response if they're immune deficient, and this is a highly effective therapy. But you need to know that the fetus is going to have this inherited disease, and it's difficult to diagnose in utero unless you know that there's a risk. Everybody thought, wow, that's fantastic, it's going to work for everything, as we all do. Unfortunately, that's not the case. So for severe combined immune deficiency, as I said, this is highly successful. But for other diseases that might be amenable to hematopoietic stem cell transplantation, there have been numerous attempts, beta thalassemia, alpha thalassemia major, liver storage disorders, and really we can say mainly unsuccessful. For diseases that might be amenable to mesenchymal stem cell transplantation, for example, osteogenesis imperfecta, there have been 6 cases, 2 with engraftment demonstrated, and 4 showing improvement in phenotype. So why is it that in utero stem cell transplantation of hematopoietic stem cells is not that effective? Well, the problem is that the fetus is actually able to mount an immune response. And not only that, the mother also transmits antibodies and also immune cells across the placenta. And in the human, the barrier is very thin. So in mouse, if you transplant congenic mice with bone marrow, you get 100% engraftment all the way through their lives. But if you transplant allogeneic bone marrow, then you can see initially there is good engraftment. But by the end, by 6 months of age, that engraftment has dropped down very, very low. And so there's a maternal T-cell response, and there's a maternal antibody response, and fetal immune response is maybe less naive than we think. So when we're thinking about stem cell transplantation for hematopoietic stem cell disorders, one of the approaches is being taken by Tippi McKenzie's group in UCSF in the US. Alpha thalassemia major is a condition where the fetus needs blood transfusions to survive to birth. And we now know these fetuses become severely anemic with high drops, as you can see here, the fluid, the ascites. And recent data shows that if you do an in utero blood transfusion when there is fetal anemia just early onset, so around about 18 to 20 weeks of gestation, these fetuses do have a good neurological outcome. So what Tippi is doing is combining an in utero transfusion with a stem cell transplant, but it's matched to the mum. So she's taking maternal bone marrow stem cells, high dose, reducing the T cells in them, and doing an umbilical vein transfusion at 18 to 25 weeks of gestation. And the first transplanted patient was done in October 2017. She's now reviewing data from 5 patients, and there is a registry for patients with alpha thalassemia major who are transfused in utero either with blood or with stem cells. And this is the data if you want to know more about this trial. Currently it's on hold, but they are reviewing the data and hope to reopen it. And the main outcome measures are going to be whether there's the evidence of chimerism. If it's more than 10%, they may not need further therapy because, of course, the advantage of this is you have the mum's stem cells available to give a booster transplant if the fetus is found to be immune tolerant. But the endpoints here are safety, particularly safety for the mother, because this requires bone marrow harvest during pregnancy. So far, they've had no major adverse events, and they're also looking at feasibility, how many cell numbers they get, the referrals, etc. So another approach targeting a disease which might be amenable to treatment with mesenchymal stem cells is for osteogenesis imperfecta, a condition that affects the collagen. In typical OI, there's a point mutation affecting a glycine residue, which means that you get loss of the triple helix. And these mutations result in a variety of phenotypes, but we're targeting severe OI, so type 3 and type 2. So preclinical mouse studies have shown that transplantation in mice that have OI eliminates the perinatal lethality. So there's a reduction in fracture frequency, increase in bone strength, thickness and length. The donor mesenchymal stem cells contributed to the osteoprogenitor population, and there was 5% engraftment after prenatal transplantation. And 2% donor cell engraftment resulted in a 20% collagen production. So this is highly effective in mice. What about in humans? So there have been a number of case reports conducted at the Karolinska Institute and at a couple of other centres around the world. And this was the first case. This was back in 2005. This was a fetus that was diagnosed with OI type 3 that was transplanted with fetal mesenchymal stem cells. These were donated from patients who were undergoing first trimester termination of pregnancy, and the fetal liver cells were harvested and were turned into a cell product. And the fetus underwent a stem cell transplantation umbilical vein of these fetal liver first trimester mesenchymal stem cells that were male, so that it was possible to actually track the cells, as you can see here. There was engraftment after an umbilical vein transplantation of 0.01 to 16.4%. The girl followed her own growth curve until 6 years of age when it appeared to drop off, and so they did a repeat donor transplantation, and she's had 4 booster doses with the same donor cells. And she's had no adverse reactions, no immune response towards the donor cells. She had a reduced fracture frequency, so 2 years before, she had two fractures per year beforehand. Afterwards, after the booster, no fractures afterwards. She takes part in gymnastics, modified hockey, etc. And a similar non-transplanted Canadian child with an identical mutation succumbed at 5 months of age. Now, of course, we know there is a variable phenotype in OI, so it's not possible to directly correlate, but it is encouraging. 4 more fetuses and infants have been administered with fetal mesenchymal cells in Sweden and in Singapore. So following this, we launched the Boost Before trial, which was funded by the European Commission, with the important outcomes to look at clinical safety, so efficacy, fractures, and exploratory quality of life, and blood and tissue analysis. Also looking at health economics and looking at ethics. So we've done a whole ethics work package, looking at the acceptability. What do stakeholders think? What do parents of children with OI think about this kind of treatment? The trial overview is 3 patient groups with type 3 or severe type 4 OI. Initially, a postnatal group of 15 children up to 12 to 18 months of age, a prenatal group of 15 fetuses with OI diagnosed, and comparison control group, untreated historical controls with 1 to 5 per active participant. And the aim is to give 4 doses of the mesenchymal stem cells, and this is the dose here, 3 times 10 to the 6 mesenchymal stem cells per kilogram. And if you think that the first, the neonate is going to be born at around about 3 or 4 kilograms, and compare that to 200 grams in the fetus, you can see here that the number of stem cells that you need for in utero stem cell transplantation is really hugely lower than you need for neonatal. Because of the regulatory applications that we did, we were required to, first of all, treat 5 postnatal patients before we could then go on to do prenatal. The prenatal participants are having their first dose by intrahepatic umbilical vein injection, followed by 3 doses postnatally. And the follow-up is 48 hours initially, with long-term follow-up until 10 years after the first dose. So before we could get ethical and regulatory approval, we did a systematic review of in utero stem cell transplantation published cases. And you can see here we had identified 54 procedures in 40 fetuses with a variety of pathologies. 38 for hematopoietic stem cell transplants and 2 mesenchymal stem cell transplantations with a variety of sources of stem cells and up to 1 to 3 transplants per fetus. And overall, the fetal outcomes were relatively good. So if you compare this to a sort of fetal blood transfusion complication rate of about 1.8%, so this is higher, but many of these studies were from the 1990s and before, and I think that the safety has definitely improved. But we demonstrated that the acute procedural mortality rate for the fetus was 5.6%, the complication rate 7.4%, with neonatal survival 82.5%. And the typical complications were things like bleeding at the site of the infusion. What about maternal outcomes? This was the primary aim of doing this study. And unfortunately, we didn't really have very much data because people are not tending to report their maternal outcomes when they publish their papers. And I think this is so important, a plea to all of you, if you're writing up any kind of interventions in the fetus, please do think about the mother, because when we want to come and do trials, we need to know what is the effect on the mother. So maternal outcome was reported in only 14 cases for the immediate period and 11 cases for the whole pregnancy. But there were no adverse events related to stem cell transplantation. So that was very, very encouraging. So we had successful regulatory approval for the trial, but it highlighted the need for us to set up a registry. So I'm going to update you on where we are with this trial. So we have manufactured the mesenchymal stem cells. They've been quality tested extensively. There's no teratoma formation in mouse models. The team did a stakeholder and patient qualitative study in couples who have a child with osteogenesis imperfecta, and didn't find any major concerns, which stopped them doing this trial. In fact, patients were really supportive of this. Not everybody, of course, but overall there was overwhelming positive support for this trial. And also a team as part of the group did a review of ethical issues, because one of the things is that the father often gets forgotten in this prenatal approach. And if you're going to do a trial which includes a fetal transplant and then follow up with neonatal boosters, the father may well need to be able to consent. And if the father is not going to consent for the neonatal boosters, then actually, are you able to actually treat the neonate after they're born? And so these were some of the considerations that came into it, because of course the father is going to be responsible for the child after birth, and it depends on which country you're in as well. So there's a number of ethical issues, and if you want to read more about that, please do look up this paper. So clinical trial development, we spent a long time discussing and going back and forth with the regulators about how to do the clinical trial. The clinical trial protocol involves taking maternal blood for donor-specific antibodies before and after transplantation, because we want to make sure whether there's any adverse events. Is the mother developing antibodies to the donor cells? As I said, it will be an umbilical vein, intrahepatic injection of stem cells. The reason for not going into the placental insertion of the umbilical vein was that we felt there'd be more likely to be trafficking of cells across the placenta and potentially exposing the mother to more donor cells. So that's why we've gone for this intrahepatic umbilical vein injection with fetal analgesia and with 48 hours of inpatient monitoring. And if you consider that for fetal blood transfusions, we probably would just monitor the fetus for an hour afterwards and then send them home. This is a lot of monitoring that was required by the regulators, but I think it's important because we want to see how safe this intervention is. The first postnatal infusion was completed in March 2020. Currently, 44 of the 72 postnatal infusions are now completed. There are only 2 more postnatal patients to go. 3 prenatal cases have been done, and there have been no significant adverse events. And if you want to find out more about this trial, you can see here. So I've talked a little bit about OI. What about protein therapy? So I mentioned this before. Prenatal correction of X-linked hypohidrotic ectodermal dysplasia. This was published by Schneider and his team in 2018 in the New England Journal of Medicine. And this is intraamniotic protein injection of this ectodysplasin A recombinant protein, the receptor binding domain. And you can see here this condition affects individuals by causing reduction in sweat production and also dentition as well. And this is an untreated older brother from one of the cases that was treated. This is the healthy control on the right-hand side. You can see the production of sweat. And this is from one of the patients that was reported. And it was an intraamniotic injection of the protein. And that's because the skin, this particular gene it's important to be normally functioning between around 25 to 30 weeks of gestation. And if you can therefore target the gene at that particular time point, then that may cause correction of the disease. And so this is a slide which are very kindly shared by Esperar and Pierre Fabre, who are running this trial. And this is an open-label, prospective, genotype-matched, controlled for primary estimand, non-randomized, multi-center, phase 2 clinical trial, essentially looking at the safety of this intervention. And women are going to be transplanted at various time points, so 26 weeks intraamniotic protein injection and 3 time points, because of course the protein doesn't last for very many weeks. And they have to be a genetically confirmed carrier of the EDA mutation. The fetal subject has to be male, X-linked HED confirmed by ultrasound or by genetic testing. The trial is open. There are 8 sites in 6 countries, 20 patients to be enrolled. The first patient was treated in France just, I think, last week. It's, as I said, intraamniotic injections. There's no post-birth treatment planned, but follow-up is needed for long-term. And it's now recruiting, and if you'd like to know more, please do contact edalifeclinicaltrial.com. So, what about other enzyme replacement? Well, there is a trial which is being developed by Tippy's group in UCSF, which is an enzyme replacement trial for lysosomal disorders. So the idea is that you confirm the diagnosis and the variety of conditions here, lysosomal disorders, which would be amenable to treatment, and you give recurrent enzyme replacement into the umbilical vein again, and then give postnatal standard care enzyme replacement therapy. And the hope is that this is going to ameliorate some of the severe effects that occur when the neonate can only be treated after birth. The secondary objective is obviously tolerance to enzyme replacement and long-term outcomes, and this trial is currently being developed. If you'd like to know more, please do contact Tippy here. So what about gene therapy? Well, gene therapy was this great big thing that emerged. I mean, I started doing my PhD in 1989, and it was a fantastic thing. It was going to cure everything. And I did my PhD in fetal gene therapy, sadly, just after the death of Jessie Gilsinger in the trial that was undergone in Philadelphia. And that really affected us all and made us think very, very seriously about safety. But it does have beneficial effects, and it's been well known now that it is effective. This is Amanda Cardoz, who had spinal muscular atrophy type 1. This is her at 7 months of age, and at 18 months of age you can see she is severely affected by this inherited condition, which is diagnosable in utero. And sadly she died shortly after this video was taken. Compare that to Evelyn Villarreal. This is a girl who had neonatal treatment with AAV gene therapy containing the SMN1 gene. This is her at 3 years of age, dancing. And, we now know that this is a highly effective treatment. So can we do this in the fetus when we can make a diagnosis and when we can have a disease which has pathology in utero? So a variety of gene therapy trials, and now things are actually being opened up and moving into gold standard clinical treatment. Types of gene therapy we could think about: in vivo gene therapy, we could give the vector directly to the fetus, injected intraperitoneally into the umbilical vein, into the amniotic fluid, intramuscular, and this could either insert the vector and the transgene into the cell, into the nucleus, or the genome, and then affect transgenic protein expression and have a therapeutic effect. So we're hoping to go for somatic gene therapy, not to target the germline, and that is one of the challenges of this in utero approach. This is an example of the more efficient gene transfer that occurs in fetal cells compared to adult cells. This is a lentivirus injection of a GFP reporter, and you can see fetal expression very highly expressed, whereas compared to adult mice, there is reduction. There's lower level expression. And this is the same dose of lentivirus into the animal, dose per kilogram. And we've also been able to target in, for example, fetal sheep, trying to target the airway, which is notoriously difficult to gene therapy postnatally. We've done intratracheal injection of reporters, so adenovirus containing a reporter gene LAC-Z demonstrated that we can get very high gene transfer into the airways using an in utero tracheal injection approach. Which diseases? So the NIH Recombinant DNA Advisory Committee reviewed this in 2000 and felt that initial application of fetal gene therapy should be limited to diseases where there's serious morbidity and mortality for the fetus either in utero postnatally, no effective postnatal therapy available. You need to be able to correct the abnormalities with the gene and have prenatal diagnosis with a well-defined genotype and phenotype relationship and an animal model for the disease being available. Now, that's quite a long list. Is it possible? Well, preclinically, yes, it is. We've known for many years, actually, work from a variety of units around the world has demonstrated that you can cure genetic disease in utero. For example, MPS 7, AAV21 into the brain, beta thalassemia into the liver, and actually another example, cleft lip and palate has been prevented by amniotic adenovirus injection of TGF-beta3 into mice that are negative for this gene, preventing cleft palate. So it's very feasible. We ourselves have done particularly work about thalassemia. This is my PhD, Panikos Shangaris, and we looked at treating a humanized mouse model of thalassemia in which there is a hemoglobin switch during development from a gamma to a beta chain, and these neonatal mice die shortly after birth. And what we demonstrated by injecting lentivirus containing the beta globin gene into the liver of these fetal mice that we could improve the hemoglobin level and we could reduce extramedullary hematopoiesis as well. And so we were able to convert this into a thalassemia intermedia, not a complete cure, but to improve the outcome. The aim of therapy probably should be long-term expression for the lifetime of the individual, which is safe, regulated at a therapeutic level. It has to be ethically acceptable, no germline gene transfer, informed consent and patient choice, and potentially does not preclude subsequent termination of pregnancy if it's found that the fetus hasn't had any improvement in their pathology. And this depends on which country would be thinking about doing this treatment. What about, is it safe? It needs to have a low morbidity for the mother of the fetus, and also thinking about the future siblings, because of course the mother's eggs are going to be exposed potentially to this gene therapy if she has a treatment in pregnancy. No insertional mutagenesis and does not affect other fetal development. One of the risks we're worried about is germline transmission. So we do know that male germline cells are at risk. This is a study on sheep following direct injection of retroviral-mediated gene transfer in utero with intraperitoneal injection. Of course, in the fetus, the gonads are going to be in the peritoneal cavity before they migrate down this is the male gonads, before they migrate down into the scrotum. But actually what they found subsequently in rhesus monkeys was that first trimester injection was the problem, whereas second trimester IP injection, there was no evidence of this. And so it's the timing of the injection which is the key factor. It's important to remember that if you don't have an integrating vector, then as the fetus grows, and they do grow very, very quickly in utero, you will get, and neonatally, you will get a reduction in the amount of protein expression. So this was a study that we did injecting self-complementary AAV8 factor 9, the vector that is currently being used in clinical trials for haemophilia. And we injected by umbilical vein injection about 50 days before the end of pregnancy. You can see the very high level of protein expression here, but then it dropped off as the lamb that was born at 6 kilograms became 60 kilograms, 6 months later. And because it's not an integrating vector, you get a reduction in the amount of protein expression. Lots of problems that need to be addressed with fetal gene therapy, including vector silencing, there's the pre-existing maternal immunity, reversion to wild-type vector. So lots of potential issues. What about, can we potentially use a sort of stem cell gene therapy approach? Can we take stem cells from the fetus and actually transduce those stem cells and put them back into the fetus again, which might avoid some of the concerns? And this is the approach that we've tested out in sheep. We've taken amniotic fluid from fetal sheep, around 10 mils, which contains about 10,000 stem cells. These stem cells are multipotential, multipotent. They can differentiate into hematopoietic stem cells, as we've demonstrated here. We can transduce these stem cells. We've demonstrated that these transduced Hematopoietic stem cells derived from the amniotic fluid can rescue mice with severe combined immune deficiency by a primary transplant and secondary transplant. And then we demonstrated that we could take this through the fetus. So we took stem cells from the amniotic fluid of the donor lamb, we transduced them, and we put them back in again a few weeks later. And then we had long-term follow-up of the lamb and demonstrated that in the bone marrow there was evidence of these transduced stem cells, and there was evidence of a green fluorescent protein in the blood. And then we were able to do a secondary transplant of the lamb bone marrow and rescue a mouse model of SCID. So it's possible to do this, but actually it's really, really difficult. And that's because you don't get very many amniotic fluid stem cells from a single amniocentesis. And so we've been looking at how we can expand these amniotic fluid-derived hematopoietic stem cells and also investigating the fetal immune response. Perhaps we could give a lower dose of stem cells and actually encourage higher levels of engraftment. We've been to the regulators to get scientific advice and have had positive responses from patient groups to this concept, but this is very much a work in progress. What about gene editing? Well, I think the difficulty is that we really are in the early days of gene editing. We know that there's genomic instability, the efficiency is poor, we're concerned about off-target effects and unexpected insertions. And this recent paper published by Kathy Naiken's group in 2021 demonstrated that CRISPR altered human embryos, 16% of them had unintended editing outcomes that targeted DNA. And so I think we have to watch this space and think about it. But gene editing potentially is one of the ways forward. What about application? Have anybody done any studies? Well, this is a preclinical study looking at in utero gene editing to treat liver disease that was published in 2019. And this was a mouse model, HT1 mice, which have long-term survival if they're maintained on the drug nitisinone, which inhibits the HPD enzyme to increase survival. But if these mice don't have this infusion, then they die shortly after birth. But they managed to successfully gene edit mice in utero. They used an adenoviral vector containing a cytosine base editor and a nonsense mutation for this, and so there was evidence that gene editing in utero may be a useful approach. But as I said, this is work in progress and needs to be followed up very carefully. So I'm now going to switch and talk to you a little bit about some work that I've been doing targeting fetal growth restriction. And the reason for showing you this is because it's about the route into clinic, and it shows you the long time that it takes to actually get these ideas through potentially into clinic. This is a condition where fetuses are born extremely small and they stop growing in the womb. And the problem is that you get a reduction in a low level of uterine artery blood flow. And so one of the ways we've been thinking about targeting this condition, it's not a genetic disease, and yet we don't know, but potentially there might be some carriers of VEGF mutations perhaps. It'd be interesting to find out. But we've been targeting, trying to improve uterine artery blood flow using an adenovirus containing vascular endothelial growth factor. And we hope that this can make uterine arteries dilate, increase blood flow, and increase fetal growth. So the idea we had back in 2005, we tested this out in a large model of fetal growth restriction and in sheep and in guinea pig models of fetal growth restriction. We then had funding from the European Commission. We did a human placenta reproductive toxicology study looking at safety. We then did a whole bioethics work package. We tested the drug out in rabbits to look at reproductive toxicology safety. We then looked at whether patients would have this condition, what's the natural history of the disease, and we're now at the point we're about to test out the clinical drug in a guinea pig model of this condition, and hopefully, I say hopefully, go for a phase 1/2 safety study in the next 2 years. The reason for bringing this up is because we've done a lot of discussion about ethics of giving gene therapy to the mother to treat a fetal condition. We reviewed the literature, we interviewed with stakeholder groups, we had an interview study with patients, and we had an independent advisory ethical review panel for the whole of the 6-year project. And this is a summary of the discussion that came forth from the stakeholder and patients. So maternal gene therapy in pregnancy itself was not a concern. And this is interesting because we interviewed patients in 4 countries, in the UK, in Germany, in Sweden, and in Spain. Safety and independent advice for patients was very important. They felt that decision-making in pregnancy affected by this condition might be difficult, but the women and the men, the couples, felt that they could arrive at a decision whether to take part in a trial if they were given sufficient time. The potential for disability of the unborn child due to prematurity was not a contraindication to the trial. So these were couples who'd had experience of having a growth-restricted pregnancy and didn't want to go there again. And some of them would have taken part in the trial if it had been available. And they welcomed an option of treatment for this condition. So I think it's very useful to go and talk to patients when we are considering prenatal therapy, because we may get surprises. Our preconceived ideas about what they might want to do may not be correct. So we've been to the regulators at various time points, including the Paul Ehrlich Institute in Germany, to talk about scientific advice about the advanced therapy and the drug product. And this was the plan for our first-in-woman trial. We definitely need to have a severe phenotype, excluding other causes of growth restriction, instilling the vector into the uterine artery, with a primary outcome of safety. And this was one of the things which was very important for us, because when we looked at assessing safety, it was actually very difficult to do this. Adverse events and grading safety is very important for clinical trials. But when we looked at the common terminology criteria, the CTCAE, for adverse events related to pregnancy, there were very few, and there was a lack of a standard severity grading. And you can see here there are only 4 events for pregnancy, including fetal death, premature delivery, and fetal growth retardation. And there were a variety of other areas that we looked at, but there was very few adverse events. And if you want to give a therapy to a fetus or to a mother in pregnancy, you're going to need to quantify adverse events to look at safety measures. And so we basically developed the first terminology so that we could look at dose escalation decisions, stopping criteria, and compare adverse events in trial participants to those women who had not had the intervention. And this is the first terminology that's available now, published here, and it's called MFET. It's now version 1.1 because we've aligned it with MEDRA, the Medical Dictionary of Regulatory Affairs. The severity grading is independent for the pregnant woman and her fetus. That's because some pregnancy conditions affect the mother and the fetus separately. Fetal adverse events were defined as being diagnosable in utero with potential to cause detriment to the fetus, and you can see here grade 1 to 5. This is the list of maternal and fetal adverse events, and there's a link here if you want to have a look at it further on our website. So I think this is a really important way to actually measure safety in clinical trials, and we're going to need to apply this for any kind of in utero therapy. So I've gone through a whistle-stop tour of where we are now in pre- and perinatal therapy. It's going to be translated into the clinic, but we have to do it carefully. It has to be safe, in consultation with patients, regulatory authorities, safety first, efficacy second, with long-term follow-up. I hope I've addressed the learning points for you, and I'm very happy to take questions or respond to any emails. Thank you.
Well, thank you, Anna. It's really fascinating, and thanks a lot for this brilliant journey through the perinatal therapy and the future of perinatal medicine. I think we have time for some questions. I would start here in the audience and later switch to the online audience, please.
Thank you. Nick Bishop, Sheffield. Thanks, Anna. That was a really nice talk. I was really hoping you might tell us a little bit about the outcome from the OI studies in terms of, you've said safety was great. You've dosed quite a number of babies now. How are they doing?
That's all I can say at the moment, unfortunately, because we're still looking at the outcomes. So yes, I mean, adverse events, we haven't seen anything significant, but obviously we are collecting up control data of untreated patients to make sure that, we've got a comparison. But watch this space, we're working on it very, very hard. At the moment, the prenatal is going well, but we've had to temporarily stop that because we're out of funding, so we're looking for further funding. But I mean, safety, so far there hasn't been any significant adverse events, which is really good. I was worried. I delivered one of the prenatal patients recently, did a cesarean section, and I was worried about, what we might find. it all appeared to be completely straightforward. But, you know, we have to be objective about this.
Great, thank you.
Thanks.
There are other questions. So we have one question from the online audience. So the question is, which medical specialty does the umbilical vein injection? Are these gynecologists, pediatric surgeries, or who is it?
So it's generally obstetricians, maternal fetal medicine specialists, but I know in some countries, particularly in the US, there are pediatric surgeons who are doing umbilical vein transfusion, but this is something that is traditionally done by maternal fetal medicine specialists, and it's done internationally. I mean, you know, many countries very, very commonly do this procedure, you know, commonly for thalassemia, for conditions like rhesus alloimmune disease. So it's very common.
Thank you. Next question.
Great talk. Thank you very much. I was wondering about the VEGF treatment. How far do you go in excluding other causes for IUGR? I mean, would you go exome?
Well, that's a very important question. That's actually, I mean, I've been thinking about that. So to give you an example, our inclusion criteria that we were developing, we initially did an observational prospective study looking at women who had a fetus that was less than the third centile between 20 and 26 weeks of gestation. And in that group, we had 5 cases of a single gene disorder that were not diagnosable in utero, a wide variety of conditions. I do offer all my patients an amniocentesis, and I do warn them there's up to a 5% chance of a single gene disorder. The inclusion criteria for the clinical trial will include things like a low placental growth factor, potentially, which will tell us more about this being a placental insufficiency phenotype. We would exclude women who had a virus infection, but it's very difficult. In that cohort, 50% in the clinical trial inclusion criteria, 50% of our women have a baby that dies, have a perinatal loss rate. And so what we're trying to do is concentrate the inclusion criteria on those fetuses, on those pregnancies that have severe placental insufficiency. But you're quite right, the more we look, the more we potentially may find a genetic cause.
Final one.
Thank you for the wonderful presentation. I have 2 questions about the boost before trial. The first one is if you are still accepting patients or eventually centers. And the second question is if you expect the same results and also including patients with recessive forms or only collagen type 1 mutations.
So unfortunately at the moment we're not recruiting because we're finishing up the postnatal treatments, and as I said, we're waiting for further funding to finish off the 12 prenatal patients. I think if this was effective and safe, then we could potentially roll it out for other genetic disorders that were treatable by MSCs. I mean, you could think about other less severe types of OI, you could think about other conditions, other skeletal dysplasias. So I think it all depends on whether we show efficacy and whether it's safe.
Okay, thank you.
Yeah, thank you.
Thank you. And then a final question from the online audience. For which conditions are you recruiting patients at the moment?
So the OI boost before trial is no longer recruiting. The X-linked hyperhidrotic ectodermal dysplasia, XLHED, is recruiting. I think the alpha thalassemia major trial is currently on pause, and I think the enzyme replacement trial is about to start. So yes, watch this space. It's getting busier in the prenatal therapy space.
I think we discussed this point before.
Yes.
So is there any chance for the human geneticist to get an overview on running clinical
Well, I think
trials,
that's
or?
something that I'll take back. So we have a group called iFetus. I will take that back to the group and actually suggest that we do have a central place for people to look at these trials. iFetus is the group that we've developed. We've published 3 consensus documents, one about stem cell transplantation, one about clinical trial development in this area. So I will take that back to the group and say, look, we need to have somewhere that people can go to get information about these trials, because it's moving quite quickly.
Well then, thanks again for this brilliant
Thank you.
talk.
Thank you.
For coming.